and the virtual Global Spine Conference. We're excited about, again, starting this new academic season, if you will, this month. We're excited to continue to be able to present this on a weekly basis to our audience. And every week we try to get some a lot of different expertise and backgrounds, and we cover deformity, degenerative spine, oncology, neuroradiology. We try to keep it diverse and as well as very informative for our participants. So this week, no less, we were very honored to have Dr. Michael Fehlings with us. I feel like we say this every week, but I'm going to say it again. Dr. Our speaker needs no introduction, but Dr. Fehlings, of course, is a world-renowned spinal cord injury surgeon, scientist. He is a professor of neurosurgery at the University of Toronto, and he's also vice chair of the Department for Research, and really one of has mentored so many people and taught so many people about spinal trauma, cervical spine trauma, spinal cord injury. I believe he is the most published scientist in this field in neurosurgery. So we're absolutely honored to have him join us. And we look forward to a great session. As usual, you can, for the participants, you're welcome to, of course, type in any questions in the chat box, as well as you will be engaging in some of these cases as well, as always. So without further ado, Dr. Fehlings, it's an honor to have you, and welcome to our virtual spine platform. Thank you for joining us.
Thank you very much for the invitation. And it's, I think, this has been one of the unexpected benefits of the COVID pandemic, has been that we've been able to use virtual technologies to reach out to one another. So it's a pleasure. So I've just decided to put together a few case scenarios just to hit on a few points of management and controversy, and perhaps to stimulate some discussion. I've no disclosures of any relevance for this meeting. So the first case kind of gets to the controversy around management of central cord injury. And this is a 45-year-old woman, and she had a trivial fall in her driveway while taking out the garbage and became densely quadriparetic. And you can see her CT scan with a significant ossification of the posterior longitudinal ligament. The axial CT is quite impressive. She's got a fair degree of cord compression, obviously. She's presenting with an AIS-C type of a picture with incomplete tetraplegia, and she was transferred to our facility within 6 hours after injury. So I guess the questions here are, she doesn't have a fracture. She's got a central cord injury. So should we manage operatively or non-operatively? If we decide on surgery, what's the timing? Should we do it acutely? Should we let her cool off? Should we do it in a subacute fashion after a course of rehab? What should be the technique? Should we go anteriorly, posteriorly, combination? What about the role of corticosteroids? So I don't know, Ali, if you want to kind of ask for questions or in the chat, or I can perhaps show how I manage the case, and then we can.
Yeah, absolutely. No, we'd love to get some expertise here. If we can go back to the image, if you don't mind, Dr. Fehlings, the previous slide. And with us also, I see here Dr. Nader Dadale and Dr. John Shin, who are both virtual spine founders and faculty. And my job is easy today because I'm not going to answer this. I'm going to have them do it. So Nader, first of all, welcome. And what do you think? Do you want to tackle this first case by Dr. Fehlings? He started out with an easy one.
Okay, thank you, Ali, and thank you, Dr. Fehlings, for joining us this evening. It's a very precious seminar tonight. So, this is, as Dr. Fehlings alluded to, this is a central cord syndrome due to a hyperextension injury in the setting of pre-existing spondylosis. In this case is OPLL. There's no fracture, although like at 2, 3, 4, 5, 6, maybe there's a little bit of fish mouth, but probably there's maybe some ligamentous injury there, but probably it's all spondylotic. So in terms of the timing, definitely patient suffered a spinal cord injury here. In terms of the timing for central cord syndrome in the absence of a fracture, as far as I know, the evidence is all level 3. Early versus late, no significant difference in outcomes. However, surgical versus non-surgical, definitely surgical surgery, decompression, and fusion have superior long-term outcome compared to just non-operative treatment. Now, to me, in my practice, what I would do for this, I would certainly wouldn't necessarily start steroids. However, I would definitely keep the patient in a neck collar. I would not mobilize her more than 30 degrees, keep her in bed, keep the maps above 90 in the acute phase, and then on an urgent basis doing it, not necessarily emergently. Like if she comes in the middle of the night, I'll maybe wait until the next morning to doing it. If she comes in during the day, I'll do it on emergent to urgent basis. And in this particular situation, I would certainly, because of the OPLL, go posterior decompression fusion long segment, probably C2 to T2 dorsally, and then decompress C3 down to C7. But certainly I'll be concerned, keep the maps up and do it on urgent basis.
Great.
Nader, that was that's definitely a plan that sounds very reasonable. I think a lot of people would agree with you. Jonathan, at the Cleveland Clinic, you guys see a few of these cases here and there. What would you, or maybe also, some of your partners do? Do you guys all have the same algorithm? Does it actually, is there actually a difference between one spine surgeon and other on how they would handle this if it were to come in the middle of the night?
Yeah, that's a great question, Ali. I really wish that this is a fantastic case. We see this all the time. It's rare that we see it in a 45-year-old patient. The typical, I would say the kind of the bread and butter case would be like a 60, 70-year-old patient who had a fall at home and they're brought in and they have numerous medical comorbidities. And I think it's perfect, as Nader alluded to, I think it's perfectly in that population. I would likely wait. And exactly what he mentioned is how I would treat this. In a 45-year-old patient, who was transferred over here, incomplete spinal cord injury, with persistent extrinsic compression on the CT and MRI, I would tend to be a bit more aggressive with this particular patient population. She has no medical comorbidities. If anybody's going to get better and recover from spinal cord injury, it's going to be this patient right here. So I would want to give them the best chance to get better. So I don't know if Nader mentioned the approach. I would take this person essentially as soon as they're stable and ready to go to the OR for posterior decompression and fusion.
Got it. Thank you. All right, Dr. Fehlings, what's the correct answer?
Well, I don't know about the correct answer, but I'll tell you what I did. So I basically treated her as I would any patient with an acute a spinal cord injury, and we took her basically to the operating room right away, and I did a posterior decompression and infusion. That's her post-operative. Those are post-operative films. We do use neuroprotective drugs, and I use corticosteroids selectively, but I do use them in younger individuals and in cervical injury cases. So we did use that in her. And then she made a decent recovery. She started recovering around 10 days post-operatively as shown. And then at 2 years follow-up, Asia D, ambulatory and independent. We have some data that will be coming out for publication, just illustrating that certainly for the Asia C central cord injury patients, that the timing does appear to matter. The Asia D, the kind of the minor, the less severe injuries, it's not as clear about the timing, and that may reflect kind of the insensitivity of the outcome measures. So there's a broad spectrum of case presentation in the Asia D. Now, if this person comes, to us at, 3 in the morning, I also won't operate on this patient like at 3 in the morning, but it usually takes a few hours to get the patient ready. But I'll operate on the patient kind of the first thing in the morning, like at 7 a.m. In the morning. And I think she actually came in during the day. So we did her sort of as a late afternoon, early evening case. So just thought I would sort of start off with this one.
Dr. Fehlings, do you use, sorry to interrupt, do you use neuromonitoring for all and any cases of cervical spinal cord injury, whether they're ASIA A or ASIA E?
Yeah, we do. We're fortunate in that we have essentially 24/7 in-house neuromonitoring, and she would have been monitored with motor and somatosensory evoked potentials. Yeah.
Out of curiosity, if all we had was the CAT scan, not the MRI, would we get an MRI before taking her to the OR? And the decision was to operate on the patient. Would we get an MRI, or would you be comfortable with proceeding without an MRI?
You're asking me?
To the panel.
Okay.
Yeah, I think the MRI is probably a good idea since the patient had an incomplete spinal cord injury, and we this question comes up literally all the time, right, John? It's and I think we all agree on the fact that if you're an institution where obtaining an MRI does not delay the definitive treatment, we usually get it. If well, hey, it can't be done until Monday and it's Saturday, then you got to do the case. So I think that's what we usually do. Dr. Fehlings, your thoughts on MRI in these types of injuries? Always, sometimes, depends.
We get an MRI in all cases, and certainly if for whatever reason the MRI was not available, I would operate based on the CT scan. But fortunately, in our facility, we have excellent access to MR. We use an abbreviated trauma protocol for the MRI, so it's a 15-minute protocol. And one of the concerns sometimes is if you have a sick patient in the MR suite, that you don't want them sort of with less than optimal monitoring and to delay, the surgery. So typically what we'll do with these cases is we'll book them for surgery, and while the operating theater is being prepared, we'll get the MR imaging en route to the operating room. And that's basically what we did with this patient.
Great, thank you.
Okay, good. Why don't I move on then to another case? So this case was a young woman. I did tragic case. This made kind of international news. She was a Cirque du Soleil gymnast, professional gymnast, and she was performing a trapeze act. They missed the transfer, and then she hit the safety net with an audible snap in her neck. She lost all movement, and she comes to us as a C4 ASIA A, so young person, no sacral sparing. And this is her plain X-rays at the time, and this is her axial image for the CT. And then this is the reconstructed view. So she's essentially got a spondyloptosis at C4-5, the bilateral facet dislocation. This is her MR, and again, it's kind of an abbreviated set of sequences. We get a T1 and a T2 set of sequences, and I don't know how many people are still using the slick injury score, but for what it's worth, this is her injury morphology, and she's clearly disrupted. Her discal ligamentous complex, and so it's a clear case for surgery, I would think. But then I guess the issues here kind of revolve around technique. So I'll sort of just show you what we do. And again, she would have received the methylprednisolone protocol. We maintain the maps, and essentially they go straight to the operating room. And then what we do in the operating room is we, while the lines are being placed, while the patient's awake, we do attempt closed reduction. And this is her, and the reduction, I think, takes a fair bit of skill, and I'm doing this. And this is actually, this case is being done in the middle of the night. This is her kind of the optimal image. And I was kind of worried about this intraoperative film with the amount of distraction that is here. So I guess this is where we're at right now. So she's C4 level. She hasn't shown any deterioration with traction, but this is kind of the optimal image I could get. So I guess my question, I might stop here. I don't think this is a case of whether the patient's going to have surgery. I don't think that anyone in this young woman in her 20s with this horrific injury would be delaying surgery. But what would people do at this stage? So I'm not able to get her really reduced with efforts at traction, and here we are. So do we go front, back, front, back, back, front? There's a whole host of options here. I'm curious what people might do.
I think we have some votes in the chat box for traction and then front back.
Okay. So this is the track. So I stopped traction here because I was uncomfortable with the fact that I was kind of distracting, but I could not unlock the facet. So here's what I do. I use a cross Caspar pin maneuver here. And this kind of shows the placement of the Caspar pins. And I place the Caspar pins in the end plates where the strength of the bone is very good. Her bone quality is excellent. And then by then essentially placing traction between the Caspar pins and straightening them, we were able to get her reduced. And she was so disrupted that this was actually fairly straightforward to do intraoperatively. And then we did this ACDF. And she has a tremendous amount of posterior disruption. So I don't think this is a good case to do through an anterior alone approach. And you'll see, even though I did not place, a very large graft, and I tried very hard to get the facets to close down posteriorly, but you'll see there's gapping of the facets. So she's clearly, would not do well with an anterior alone. So we did her, so we just flipped her over and we did a posterior fixation and a posterior decompression. I don't know if any of you have kind of seen what a post-operative MR looks like in the early stage, but if anyone doesn't believe in the concept of secondary injury, I've got news for you. This is what secondary injury looks like. It's just horrific in terms of seeing the extension. But fortunately, she did not have an ascension of her injury. And this person is at really high risk for getting an ascension of her injury and ending up event-dependent tetraplegic. But fortunately, that doesn't occur. And in these cases, you look at this imaging, there's no way on God's green earth this patient is going to convert. So this is not going to be kind of one of the 44% of Asia A patients that will convert. But you're fighting for levels, and you're fighting to keep her off the ventilator and to try to get whatever levels. So basically, this is kind of her long-term follow-up film. I think this is a year follow-up. She's now many years follow-up. Unfortunately, did not convert, no surprise. She did retain one motor level. She's actually in the community, and she's actually, she's obtained her journalism certificates. But, so not all of the, the early decompress, as you all know, not all of these cases are home runs. This is not a home run, but I still think that in this patient that, early surgical intervention, helped her and certainly enabled her to prevent an ascension of her injury, and she, was able to regain a level. I don't know if there are any comments or questions.
Yeah, sad case for sure. Dr. Fehlings, a couple questions from the audience. The first one is, did you do a posterior laminectomy as well? Or just the instrumentation?
I did a laminectomy as well.
Okay. And I think there was a question a little bit earlier about your, the methylprednisolone question, which this is not going to be a methylprednisolone talk, I know, but since you mentioned it, one of the participants wanted to know whether you feel differently in utilizing that for complete versus incomplete, or do you have a preference, or is it you just routinely use it regardless of the degree of injury?
The methylprednisolone's imperfect. My position on this is stated in the 2017 Global Spine Journal Systematic Review and Guidelines. So it's an option. There's a strong basic science basis around trying to mitigate inflammation. The problem with methylprednisolone is it's the same problem as like with cooling. You're immunosuppressing the whole person when what you really want to do is to reduce the inflammation at the injury site. So what can you get away with? So younger people without medical comorbidities will get away with it. And then who's it worth it in? The cervical spinal cord injury cases are probably the optimal case to consider using a neuroprotective drug like methylprednisolone. And there, I would use it regardless of whether somebody was a complete or incomplete injury. The rationale for this is you're fighting for level. So even in a complete injury, like in this young woman, there's an area that's a complete injury at the core of the lesion, but there's a penumbra area around the lesion, as you recognize, you could see on the MRI, where this is a zone of incomplete injury. And so I think that's the rationale for using the medication. And currently, we're just wrapping up a randomized trial with riluzole, which is a sodium channel a blocker, and the early results appear promising with riluzole. So we would likely, if this person would have come in now, we would have likely added riluzole as well to the treatment. Okay, I have a few other cases if we have time. So here's one. And so as was mentioned earlier in the discussion, the demographics of spinal cord injury are changing. And this case that I'm presenting here is not atypical. Person in their 60s with medical comorbidities, and we're seeing more and more. So this is a guy, he's 61. He's got a history of atrial fibrillation. He's on warfarin. His INR was quite appropriate. And he had a bit too much to drink. He fell, was intoxicated, was seen at an outside facility, had some x-rays done. They apparently didn't show a fracture. He was sent home. 3 days later, things aren't going so great. He presents as a 911 emergency, represents the emergency room, and he's now got significant neurological deficits, and he's transferred to my hospital, where we examine him, and he has now a motor complete, sensory incomplete cervical spinal cord injury. He's a T4 sensory level, some patchy sensory sparing. Lower limbs are 0, and he's got grade 3 power at the C6 level wrist extensors, and his triceps and his fingers are 1 out of 5. So quite a fairly catastrophic deterioration. And these are his films, and maybe I'll just leave it there. And if anyone would like to perhaps comment on what they think is going on, and what other imaging we should get, and what sort of management we might want to consider.
Good case. Nader, what do you think? Do you want to tackle this one?
Sure. Looks like this patient has an ankylosed spine, probably has ankylosing spondylitis, and I think there's maybe a fracture through the 2, 3, 4, 5, at 5, 6 here, kind of a fish mouth. And these are subtle injuries, and but they're very unstable, because usually it's a 3-column injury. Fractures in patients with ankylosing spondylitis or DISH, they're usually 3-column injuries, extension type, and they're subtle. and they can be missed, but they're very unstable. You know, you can't mobilize these patients. So yeah, I mean, I think I would put them in a neck collar and then get an MRI of the cervical and thoracic spine just to, and plus sometimes they have contiguous, like 2 separate areas in the spine that can be fractured simultaneously, tandem injuries. So I'll get maybe put them in a Miami J collar, won't mobilize them, get a cervical spine MRI and maybe a thoracic one since he had a sensitive level at T4.
There's the MRI. I agree with your comments. Your thoughts on the MRI?
Okay, yeah, he was on Coumadin, so that he has also an epidural hematoma in addition to the fracture, and he's prone. The bone is brittle and can bleed, and he's on Coumadin. So yeah, we have the diagnosis. So as an unstable fracture, it's subluxed a little bit on that MR. You can see the middle image here. There's a little subluxation, totally unstable. So he has a 3-column injury at 5/6 and an epidural hematoma from bottom of C2 to C5. So
yeah, it's perfect. So I remember this case very well because we were hosting the NAS meeting in Toronto. I was talking about management of spinal complications of ankylosing spondylitis, and I got a call about this patient. Very ironic, and you can see the fracture here on the MRI even more clearly than the CT. But you're quite right. The findings can be can be subtle, and it shows the danger of relying on plain radiographs in this sort of situation. So I think I don't think anybody's going to manage this person non-operatively. I just put this up kind of for amusement. And then I guess in terms of surgical approach, we clearly have to go posteriorly because of the epidural hematoma. Would anybody consider doing kind of a posterior anterior, or would people rely on a posterior alone? What would people do here with this sort of a fracture with the epidural hematoma?
Yeah, definitely. I'll take that one. We're getting a few responses, mostly posterior. A couple of folks would do posterior only. That certainly would be my choice, since I see the ventral, the anterior column appears to have realigned, at least in that one cut. I think posterior reasonable. I did have a question about the treatment of these with hematomas. If you see an spondycervical fracture that needs to be repaired surgically, if the patient is intact and there is no hematoma on MRI, would you decompress anyway because there's a chance of bleeding when you fuse, or if they sublux a little bit on the table, or would you only decompress if there is a symptomatic hematoma?
Yeah, so it's a really good question. I think so. The MRI here, I think, is essential. So I would not, let's say somebody was neurologically intact, and let's say the MRI did show cord compression, which sometimes will occur because these people can have sort of subclinical cord compression. So I think if they had cord compression, even if they were neurologically okay, I would decompress the at least across the fracture site to deal with the concern you have. If the cord looked perfect and there was an ample subarachnoid space, I would not decompress. But many of these cases kind of have focal stenosis as well, and so very often I'm finding that I'm at least doing a focal laminectomy across the fracture site. But if the space is wide open and there's no hemorrhage, then I won't necessarily do that. So I'll show you what we did. Then I think that's fine. So, this patient clearly needs surgery. I think I had these slides when when we were big on the slick score. But I still think from some of the principles, it's good because, you know, the injury morphology is highly unstable. I really agree with Nader's comment. So it's really deceptive, but they're, you know, these patients are completely unstable, and it's got a, you know, cord injury, it's got ankylosing spondylitis. So basically, medical management, reversal of the anticoagulation, and so on, inotropes to maintain the MAPS, and then basically did a posterior decompression and fusion, dealt with the epidural hematoma. And, you know, I think as has been suggested in the discussion, you know, the bone quality is not always the best, and you've got a long segment of ankylosed spine. So you want to have multiple points of fixation above and below. And in somebody like this, I'd be hesitant to base the upper end of the reconstruction on a C3 lateral mass screw. So I think going up to C2 is probably a good idea. And this is the post-op MRI, so he's nicely decompressed, and he actually, fortunately, thank goodness, made an excellent outcome. Was completely intact at a year. Had a little bit of a stormy course initially in the post-operative period, which isn't surprising given his age and the severity, but we got him through that. So I've got a case here that I just did recently. This is actually a very recent case. It's also a bit of a sad case. You know, a lot of these cases are sad. This is a young woman, she's 28, and she's originally from the Congo, is Canadian, but was on vacation in the Congo and was involved in a motor vehicle collision, 160 kilometers an hour. She was not seat belted, she was a passenger, and she was ejected from the vehicle. So very high velocity injury, and was immediately quadriplegic at the scene. And we got her records, and she had a whole host of medical complications, which are listed on the slide. And she underwent a C6-7 anterior cervical discectomy infusion with a plate and a PEEK cage. And you'll see what the surgery looked like. And then she was eventually repatriated to Canada. She was initially felt to be quite unstable medically. And I don't know if COVID was an issue or not in the transfer. So she was transferred to our rehabilitation facility. And what is normal is that they will obtain a consultation, but after arrival, it was fairly quickly noted that she wasn't doing well. So she had severe neck pain and shooting pain into both arms. And her exam is, she is an Asia A cervical level. She's got some asymmetry. So she's C6 motor on the right and C5 on the left, and the sensory levels are similar. So I'll show you what her imaging looks like. So this is her original post-injury films in the Congo. So she was treated at a private facility. So the imaging is of good quality. And she's effectively got a spondyloptosis at C5 and C6. This is not too dissimilar to the injury in the trapeze artist that I showed earlier, but this injury is actually more severe. So she's got posterior fractures, and she's effectively got a spondyloptosis at this level. They did obtain a magnetic resonance scan, and one can see the severe degree of cord compression, the spondyloptosis, and she also has a rotational injury. She's got a lot of soft tissue disruption. So she was treated with a C6-7 ACDF, essentially with a short segment plate and a PEEK cage. And these are her films after repatriation. And so you can see that effectively she's sort of dislodged the alignment further in the coronal plane. So here's the top end of the plate here. It looks almost horizontal on this film. And then here are the screws here at C6. There's this cage. And then here are the screws at C7. And this is the reconstructed sagittal and parasagittal images. So this is in the midline, C5, C7. So this burst fracture isn't really, but she's got significant kyphosis and intrusion in the canal, and she has she actually had a perched facet on the right side, and she had a dislocated facet on the left, persisting here. These are some axial images here, so you can see the persisting laminar fracture. It looks like there's partial healing of the laminar fracture on the opposite side. And then this is C5 and this is C6. You can see some of the remodeling of the lamina here. This is the cage, which is sort of floating in the middle of this business. This is her magnetic resonance image. So she's got a severe, injury, a lot of myelomalacia. She has persisting compression here between C5 and C7 at the C6 level. This is the axial image. I went ahead and got a CT angiogram, and so the vertebral arteries and the carotid arteries are intact, but you'll see that the right side of the plate is touching and is actually displacing the carotid on the right. And this screw is awfully close to the vertebral artery and might even be displacing it slightly, but certainly quite close. And I got an ENT consult. Her vocal cords were intact, and we got an esophageal contrast CT. So the esophagus was intact. She had no clinical evidence of dysphagia. So in summary, this woman is presenting to us with a cervical spinal cord injury, C6 motor on the right, C5 on the left. She has coronal and sagittal displacement of the upper plate with kyphosis and coronal and cord compression 5 to 7. She has severe pain, bilateral shooting arm pain. The plates and the screws are close to the carotid and the vert on the right side. So the question here is, what should we do? And I don't know which image. Maybe I'll show that image here or that one. How do people want to tackle this one?
What do you think, Jonathan? I know there's some thoughts of front back or back front back. Dr. Asuli, what would you do here?
This is a nightmare, unfortunately. It's a very, very challenging case with multiple technical considerations. So no doubt this patient needs surgery given her clinical presentation and findings on imaging. The question is whether you can accomplish all. Now, she has previous surgery in the front with a screw that could potentially be up against or somehow it potentially has violated the vertebral artery on the right side. And the patient obviously has a 3-column injury with kyphosis. So the question is whether you can accomplish all your goals through a posterior only approach and avoid any of the basically the mess that she has up front, or do you have to treat both? And if you're going to treat both, whether you do this in a kind of a back front back or a front back or whatever you think is appropriate. So I think no doubt, I don't think, given what you see, the severity of the injury and her hardware that she has there, I don't know if you'd be able to accomplish all your goals to the back. You can certainly attempt to place this patient in traction and see if you can get all your alignment and see if you can just get ligamentaxis and see if she restores her proper alignment and everything up front. But I don't think that's going to help her. I think it's C5 vertebral body fracture there. So I don't know if that's really going to help. So I would lean towards doing a front back or potentially a back front back. But when you are dealing with the hardware up front, I think you would have to be ready to deal with a potential vertebral artery injury during surgery. So I would make sure you have neuromonitoring, you have a fresh team, you have everybody, all hands on deck for to deal with that. So I would probably do 1 or 2 level corpectomy there, get that out, stabilize her anteriorly, have everything on board to deal with that vertebral artery injury if present. Maybe it's completely fine and no issues at all. And then I would do her posteriorly. So I would do a front back.
It was a very good discussion. So I'll show you what we did. one of the challenges was trying to figure out what sort of hardware she had. So I felt that I would need to remove the hardware and to try to get some direct decompression, and then to try to mobilize as much as I could anteriorly. And my plan was to go front back, but depending on what I was able to accomplish from the front, I also discussed with her that I might need to go kind of front back front, but I was going to try to avoid this. And I felt that, you know, my goals here were to decompress the spinal cord and nerve roots, to try to deal with, because she was having a lot of root pain as well, to try to get improved alignment, so to try to deal with the segmental kyphosis, try to get some coronal alignment, and then get correct stabilization. And I wasn't aiming for a perfect result here. I don't think that was necessarily kind of in the cards. And then when I'm going through a revision surgery, I often will place my incision on the opposite side to what was previously done to reduce the amount of scarring. She had a previous right-sided incision, but I elected to go through the right side because I wanted to have access to the carotid artery. So here's essentially what I do. I don't have any intraoperative films, but I can show you the post-operative imaging. So basically, I went front and back in her. I was able to remove the hardware. It's interesting. I sent her images around, and I was able to get some of her operative record, some of her hospital records, but not her operative records. I don't know what kind of a plate she had, but her images were kind of sent around to a number of manufacturers, and as best we could determine, this was a no-name plate made in Nigeria. And I was able to remove the implants fairly easily, kind of with a universal removal set. And then once that was done, the case was actually surprisingly straightforward. We did get control of the carotid and the carotid sheath, but the carotid sheath was not violated, and so we were able to actually very nicely separate the carotid sheath from the plate, fortunately. The one screw that was close to the vert, there was no problem removing that. It was quite loose, and it was that was all fine. And then we essentially did a corpectomy and anterior reconstruction. And very interestingly, during the anterior portion of the procedure, we monitored with motor and somatosensory responses. She had biceps and deltoid motors, and nothing below that. But after the decompression, we then had triceps motors that were coming in, and we had recovery of the left median nerve SSCP. She did not have a median nerve SSCP prior to this. And then we flipped her over to the posterior. So that's essentially what we did. So we got her close to neutral alignment at the injury site itself. She had about 70 degrees of focal kyphosis preoperatively, and she's about 3 degrees. And this is her CT scan. So her canal, I think, is decently decompressed. I'll get an MRI on her at some point. I just operated on her last week, actually. She has actually recovered 1 motor level on the right and 2 motor levels on the left. So she's a C7 now. And that's a pretty big deal for her, because it means that she'll be able to extend her arms, which is quite significant, as all of you recognize, in terms of her transfers. These are just a few representative images. So she's a little bit still offset coronally, but she's better than before. And then she's got, I think her canal is pretty pretty open. So, you know, one of the challenges here, I'm sitting on a WHO panel, and they're actually talking to us about the management of patients who are either injured in disaster zones or injured in developing countries or the emerging economies. And my advice actually was that patients would likely be better off not having surgery and having medical management and being packaged and, if possible, shipped out. And in this case, I certainly kind of comes to mind. I don't know if there are any further comments on the case, and I have one final case if we have time.
Yes, thanks, Dr. Fehlings. We absolutely have time for one more case. This is, as people are saying, this is an incredible save, technically and clinically. One thing that has come up multiple times, so I thought we would just talk about it now, is the assumption is that on many of these injuries, you are obtaining a CTA, and in the event that there is a dissection that is not acutely symptomatic, are you placing them on aspirin and operating that, and then operating, or are you just doing the case and say 7 days or 10 days after you are placing them on aspirin? Or what's your protocol if you identify a dissection, but the patient needs an urgent or semi-urgent operation?
Yeah, that's a great question. And so in the I'll talk generally, and I'll talk perhaps about this about this case. So I think, in this patient, if there would have been a dissection kind of chronically, I probably would have considered getting an opinion from interventional radiology and to see whether it made sense to put her on a stent, beforehand, because I might have been concerned about any manipulation of the vert kind of intraoperatively. And I might have just operated on her on aspirin. In the setting of like a facet dislocation, like the trapeze artist that I showed earlier, very often I did not show her CTA. I obtained a CTA on her as well, but you'll find that it's actually kind of hard to tell what's going on with the vessels because there's a lot of displacement of the vessels. So usually I won't do anything, and then I'll get the realignment and I'll get a CTA post-operatively. And most of the time the vessels are okay. If there is a dissection and the patient is not symptomatic, our protocol is to put the patient on platelet inhibitors. And then if the patient is symptomatic, which fortunately is rare, then a kind of a more aggressive anticoagulation protocol plus minus an interventional approach will be taken.
Great, thank you for that.
Okay, great. So yeah, so this case, and I think one of the lessons here as well is that, although, clearly in this patient, there's no way that we were going to be getting cord function back, but it is quite interesting to see the impact of decompression on recovery of local kind of nerve root function, which I think will be quite helpful for her. So just something to kind of to bear in mind. And that's a very important goal to try to achieve. And then the other thing here as well is, although I'm a big proponent of early surgery, you'll get these cases referred into you for all sorts of reasons in delayed fashion. I wouldn't be nihilistic about offering patients a decompressive surgery, even in a delayed fashion. So the final case, this is again in the theme, this is now another kind of older individual. And this case has got lots of twists on it. And, in case you think we always get everything perfect in Toronto, we don't. Like, we also struggle, like everybody else does, with diagnoses. And this case was a bit of a struggle for us as well in the team. So this is a 69-year-old guy. He's got upper C-spine fractures, but it's complicated by some vertebral-basilar issues. So he's 69. He's a drinker. He has thrombocytopenia, hypertension, and he was found at the bottom of stairs intoxicated after a fall, neck pain, left-sided weakness. And then he was brought into our emergency room with essentially what was felt to be a left hemiparesis. He was a bit obtunded, just slightly, whether it was from the bonk on the head or a bit of residual alcohol wasn't clear. And then he was felt to have had a stroke. So neurosurgery was initially not involved, spine wasn't initially involved. He was actually managed medically initially by kind of neurology, neuroradiology, and then a consult was obtained. So, you know, whether that was the right approach or not, you can, but anyway, that's how he was initially managed. So during the course of the imaging, you know, and they got a whole bunch of imaging on him, and I'll show some of it. They did get some scans through his neck, and that's kind of when we were initially consulted. And initially, one of my general neurosurgery colleagues was involved, and then I got consulted on this. So he's got a C1 ring fracture, and he's got a fracture through the base of the C2 pedicles, and then he's got a laminar fracture on the right. So that's a real fracture right there. So he's got a C3 laminar fracture. This is his alignment here on the films. So he's got no displacement here. He's got some spondylosis kind of here at 2, 3, and this will be better shown in some other imaging in a moment. So because he was kind of assessed as a possible code stroke, they got a bunch of vascular imaging. Got a CTA, which was felt to show a possible basilar right vertebral artery dissection. Then they got a formal angio on him, and he had no flow in the right vertebral, and he had chronic stenotic disease in the basilar. So there's his basilar artery, and it was felt that he had a combination of a right vertebral artery dissection and then chronic occlusive disease, kind of atherosclerotic disease in the basilar. So a bit of a complicated picture. Then he obtained MR images to try to figure out what was going on with him further. And then he had this high signal within the cord. And there was, you know, some discussion going on initially whether, you know, this could possibly be kind of an ischemic cord injury versus a traumatic kind of a traumatic cord injury. I'll point out that he's got some high signal posteriorly in the soft tissues, and there, you know, there's a suggestion of some increased signal here, and I think this is real. And then he's got kind of some high signal kind of within the cord. So this picture is far from clear. Just see here. Oh, there we go. Yeah. Okay. Yeah. I'm just trying to point out a few things. So there's the cord contusion. He's got some high signal here. And I think those changes on the CT probably represented a very subtle fracture of perhaps some spondylosis at 2, 3, and he's got some ligamentous injuries. So he's got some changes here, but fairly, fairly subtle, but they're certainly there. And there's this cord contusion. Okay, so here's the imaging summary on this guy. So he's got arch fracture of C1, C2 Hangman's fractures, and Levine-Edwards type 1, so it's involving the foramina, C3 laminar fracture, C2 cord contusion, and I think he's got high signal in the stir images in the 2-3 disc and the posterior ligamentous complex. And then no evidence of ischemic injury in the brainstem, and he's got these occlusive changes. There was some discussion whether it was a dissection on top of atherosclerotic occlusion or it was just atherosclerosis, and then kind of the basilar vessels. So then, so while all of this stuff is being figured out, he kind of developed respiratory issues, was intubated, was kind of medically unstable. He then developed a VAP. So we kind of felt that he was medically unstable. So I guess the discussion points here were, how should we manage this guy? Should he have a hard collar, a halo, operative fixation, the timing, is there a role here, even though he's sick from the VAP, to do early surgery, or can it be delayed? And how would this be done? So I guess I'll maybe ask that question. Maybe I'll go back to the there's the imaging summary, and there's the MRI, and there is the Axial Ct. So
yeah, I guess I'm going to put myself on the hot seat here and take this. In looking at the CT, I would have almost sworn that I would put all my money on a stable injury, put him in a collar. We say this all the time in other sessions, but I'm a big fan of getting upright x-rays to make sure that there is no difference in the alignment between the supine CT or MRI and the upright x-ray. But now the MRI has kind of confounded the picture for me a little bit. I didn't think there would have been a kind of an unstable injury there. And I may be in the minority, but boy, I would still put him in a collar and get an upright x-ray. I'm just not convinced that there was motion there to cause a cord contusion, but I may be wrong. I would start conservative with him.
Okay, so maybe just for the sake of time, because we're almost out of the hour, so that was certainly kind of the discussion. And I don't think that your view on this is necessarily incorrect, but I get you can sort of guess what I did. And I operated on him. I allowed a week's delay for medical stabilization. I felt that he did have a cord injury. He did not have cord compression. And I kind of thought this guy was kind of sick, and I didn't know how well he would do in a kind of a collar immobilization, but I think what you've mentioned is certainly a valid option. He had a bit of a high riding vert on one side, so I placed kind of a shorter par screw on this side, and then kind of a longer pedicle screw on the opposite side. And then I didn't think he needed an occipital cervical fixation, but this is kind of what we did. And then he had a fairly prolonged ICU stay. He kind of had a Brown-Séquard picture from the C2 contusion. And then he made a decent recovery at about a year. So he was transferred, and then was he had kind of residual Asia D with some mild residual left hand weakness. And so I think, some of the points here, I think it's clearly complex anatomy here. So, have a high index of suspicion for vascular injury with high cervical combination fractures. And then spinal cord injury can occur in the absence of ongoing compression. My concern was that he had a high-grade ligamentous instability, and he had effectively dislocated the spine, and then he kind of relocated. But there was a lot of debate initially in terms of whether this could have been a vascular distribution injury, but in the end, it was concluded that this was a contusive injury. And I guess this kind of reflects my bias that the early fixation enabled earlier access to rehab. So basically, once we'd stabilized him, it kind of took the issue of whether or not there was any kind of spinal instability out of the equation. So it kind of facilitated his mobilization. So I'm just going to stop sharing.
Wonderful.
The screen there. And
thank you. Yes. Thank you so much, Dr. Fehlings. That was that really did capture I would say, the essence of this platform, which is a case-based interactive session. So believe it or not, it's not easy to pull off, and you've done it beautifully. So we are on time, and we like to start and finish on time. So certainly on behalf of my colleagues, the virtual spine faculty and panelists, and really all the participants today, we want to thank you for joining us, and we definitely would love to have you back at a future date. Thank you for doing this.
My pleasure. I have many other interests, as you know, and I love these case formats, and I thought the interactive discussion was great. And I can assure you, the last case was far from straightforward in the decision making. I kind of agonized over that one as well. It all looks easy when you're presenting it kind of from the armchair with the PowerPoint slides, but I thought the discussion was a really good discussion. I've tried to capture a few of the challenges and kind of controversial points and give you a little bit of a flavor of my own perspective. So thanks very much for the invitation. Have a good evening, everyone.
Absolutely. Thank you. And Dr. Fan will be hosting next week, and we will see everyone next week. Take care, everyone.
Take care. Good evening.
Good night. Thanks, Dr. Fehlings.